Okay, thank you. Thank you, Chairman, for the very kind introduction. And I wish to thank Professor Philip Lee and also Professor Juliana Chan for this kind invitation for me to present a topic on collaborative care from the patient and provider perspectives. I don't have any real conflicts of interest because these companies where I participated in do not seem to produce any medications where I will have some sort of benefits. So Professor Chan actually asked me in an email, how about if you present a study on the adoption of reference framework for diabetes care among primary care physicians in primary care settings. I thought, well, it's a very nice idea. This one was actually funded in the year 2010 by the HMRF, and subsequently the primary care office, at the time is called primary care office, also sponsored us another study. And very surprisingly, indeed, the findings of the two studies on evaluation of adoption of reference framework for diabetes are actually very, very similar. So in that case, I don't duplicate by presenting both studies, but just the one we performed 10 years ago. So this is the rising prevalence. By the year 2035, we would expect the prevalence of diabetes both globally and locally to be affected in terms of 592 million people being affected globally. And this is the geographical variation. My students always ask me, come on, in Hong Kong, there's a red dot. Is it representing that our diabetes control is poorer as compared to the other countries? But I think, well, probably, yes, we can see a rising endemic of diabetes locally in Hong Kong as well. So this is the expected geographical variation of diabetes in the year 2025. And 2030, we have 13% of our populations being affected by diabetes, and which, well, is consistent with what has been presented by our previous speakers, talking about very few achieve optimal hemoglobin A1C goals, 58% only, blood pressure, 38%, lipid, 36.4%, and the targets, low weights for BMI control. And a number of them got poor weights of nephropathy and retinopathy screening. And the weight for retinopathy is really just about 38%. So that actually calls for a need for, say, RAM program, J program, a number of PPPs, and also the recent chronic disease co-care program launched by the Primary Healthcare Commission. So for management of diabetes in primary care settings, we do think that one cornerstone for medical doctors to look at would be the guidelines. And in the primary healthcare office now, we do have 4 guidelines, and one is dedicated to management of diabetes, and the 5th one is on musculoskeletal disorder. And because primary care practitioners offer first contact and continuous care, and also we are the person who very frequently play coordinative care. That means we coordinate with nurses, allied health professionals, and also community resources. We do think that there could be a positive impact of evidence-based recommendations on quality of care. So therefore, the guideline has been on diabetes care have been released in 2010 in various forms. So for the primary healthcare office reference framework on diabetes care, this framework actually represented a comprehensive and life course and continuous approach, having some sort of best evidence produced by an expert panel of physicians and also relevant stakeholders. And it adopted patient-centered care, and therefore it is expected that the adoption of the guideline could facilitate better diabetes care in a primary care setting. I don't think I need to actually quote any evidence, because I'm sure you're all very familiar with the different types of evidence which supports the effectiveness of the guidelines to reduce hemoglobin A1C, reduce morbidity, various complications, hospitalization, and mortality. So it has components of primary prevention, lifestyle changes, assessment of high-risk groups, early detection, as well as management of diseases. Now, this is what is actually typically in our general outpatient clinic desktop. So this was produced in the year 2010, and now I thought it was updated in the year 2018, subsequently 2021, and this is actually free of charge, which could be downloaded in a link here. And then we have a one-page summary of the management and assessment of diabetes in primary care using a very succinct and concise presentation style. And therefore, we can actually retrieve very quick information from this slide. So I would like to actually present a descriptive study, which is only a survey to enlighten a number of perspectives from the doctors and the patient's point of view. So firstly, the aims and objectives of this project is to evaluate the awareness and adoption levels of the framework for diabetes among primary care practitioners in Hong Kong. Now, the findings still hold true even now because we have repeated exercises of evaluating the different perspectives, the enablers and barriers of using the adoption levels of the guideline. And there are not much changes as we have just highlighted. And to study the factors associated with the reference framework's adoption in terms of the enablers and the hindering factors. So we conducted focus group interviews. So we have invited at least 5 groups of PCPs. I thought we have increased the numbers afterwards with at least 2 focus groups for each and 6 to 8 Cantonese-speaking participants per group until we reach data saturation. Involve a broad range of participants, including those in solo practice, health maintenance organizations, general outpatient clinics, those who are academy fellows or teachers, or those who practice in more specialized clinics, such as the family medicine specialist clinic. And apart from open-ended questions for our primary care practitioners, we also evaluated the factors which enable them and hinder them to adopt the guidelines, as well as their attitudes and perceptions of whether they use the guidelines and the reasons why. And these are really just some of the sample questions of how they think about the reference framework for diabetes care produced by the primary healthcare office, and whether they think the framework can really help them in their clinical practice, whether there are any hindrances in terms of their daily work, etc. And of course, they are actually recommended to give some suggestions and recommendations to modify the guidelines if there were any. So we use standardized methodology using the different 8 domains as a conceptual framework using the guideline implementability framework. So this would include usability, adaptability, validity, communicability, etc. So after we transcribed them, we generated narrative themes by close reading of each of the transcribed interviews. And study 2 is a cross-sectional survey where the sampling frame included the target populations of all registered primary care practitioners in Hong Kong, including in the public and the private. So in the private sector, we approach quite a number of societies and organizations to retrieve their databases, because it's actually quite hard to reach the private physicians nowadays. So the invitations were therefore sent to more than 3,000 primary care practitioners in total, and then in different formats, emails and paper. We estimated a minimum sample size of 400, and this is really just talking about the different sampling strategies which have just been mentioned. Hard copies forwarded to the primary care clinics in the public sector, and in private, we do have posts with self-stamped envelopes and the different strategies, including emails and fax lines. So the study instrument of the questionnaire is actually, we tried to make it as robust as possible, because when we designed it, we make reference to international literature, tailor-make it to local context of primary healthcare in Hong Kong, and the question items were then therefore phase validated by an expert panel in the Chinese University of Hong Kong and the Hong Kong College of Family Physicians. After its pilot testing, they were then self-administered. So these are really talking about, we produce an overall adoption score where 4 is highly adopted and 1 is poorly adopted. And the this is actually the major outcome, but we are also very interested to see the strength of association between the enhancing factors, hindering factors versus the adoption level, controlling for the different potential confounders. Now this is our findings. We performed 10 focus groups with 60 Cantonese-speaking primary care practitioners. These are the age and the gender characteristics and practice experiences. So most of them are actually quite experienced. Some of them are actually have practiced for more than 30 years. None of them less than 5 years. So at least they're actually a very experienced group of primary care professionals. And the clinical practice, we got, more or less equal participants from the public and the private. Now, I would like to actually highlight this slide, which are the recurrent themes when we're trying to conduct over the years. So what are the major barriers for guideline implementation? Now, firstly, they're in fact actually very much concerned whether the frameworks have been up to date or not. Now, in fact, recently there were a lot of medications for diabetes, and the primary care practitioners are simply very confused on which one is now the most recommended by the guidelines. And when they actually ask us, is it all right I go to the ADA website or I go to the other international experts to seek for which one is the best first-line agent? They thought that this might not be applicable in Hong Kong. And secondly, they are really concerned about the patient's compliance. So if the medications are new, effective, but will they have any side effects? And also whether they are affordable by the patients in terms of whether the screening tests offered to them in a private settings could actually be well received by the patients. And also concerned about limited consultation time, long waiting time for referrals to allied health professionals. So whenever there are complications of diabetes, and if I'm going to see a podiatrist or dietitian in the public sector, will it be very easy and readily accessible? So these are the major questions. Inadequate allied health support are some of their perceptions, and also clinicians' common practice should be based on their own practice. So some of the physicians actually express that their autonomy has been compromised by the guideline, where the flexibility of referrals and management could be guided or led by a reference framework. And lastly would be difficulties in prescriptions, which is very understandable, because in some of the private practices, the prescriptions are probably not from their own choice. It's also really dependent on the organization availability. So for study 2, we completed more than 400 surveys with the good news is that the average adoption score of the reference framework among these primary care professionals was 3.29, which is actually quite good out of 4. And in fact, 70% of the primary care practitioners highly adopted the reference framework. So we can actually regard that as quite good news. And this figure is actually consistently over 70% when we actually conduct serial surveys over years. And these are some of the participant characteristics of the quantitative survey. Their practice experience, they're even more experienced as compared to the qualitative study. And most of them are now in the private practice. And these are some of the results we found quite interesting. The red highlighted ones are those recommendations where they practice slightly more frequently as compared to the others. But interestingly and slightly surprisingly, when we actually ask simple statements extracted from the reference frameworks, like, do you consider hemoglobin A1C level of less than 7% as optimal treatment goal for all diabetes patients? Only 57.9% of them responded yes. And did they set target blood pressure as 130 or 80 or below? 54%. So initially, we really don't actually trust these results. But interestingly, over serial questionnaires, they do have actually different opinions. So it's actually from a physician's point of view. But quite a lot of the participants, they actually advise all patients to maintain optimal body weight in their consultations and adopt healthy lifestyle, including healthy eating, and all diabetes patients should increase their level of physical activity and with regular exercise, and also advise all patients to stop smoking and also measure the blood pressure. So these are all highly adopted, so as compared to the other domains which are performing less well. And for the other recommendations, these are not as adopted as satisfactorily. Now, these were actually documented in the reference framework, but only 30% or even lower recommended eye examination, made frequent eye examination if the control of glucose and blood pressure were suboptimal. They do not actually, a lot of them do not recommend food care education as part of multidisciplinary care, and they did not actually screen all diabetes patients for foot disease annually. So these figures are somehow alarming. And there are other factors determining high adoption versus low adoption. So these factors are what we call the guideline-related potential influencing factors. So including inclusion of essential clinical information for diabetes management. So 95% of them actually agree that in the future, the guidelines should include essential clinical information for diabetes management in all the aspects with sufficient local information. So the medical doctors like local context rather than just an international guideline, because they can actually search it very easily in the ADA website or the other websites like the Big Show. And also improving patients' knowledge on diabetes management and also having updates on information of the framework. And importantly, the guidelines should include sufficient recommendations with high validity and also having adequate and high quality evidence. So these are the aspects of the reference framework which they treasure a lot. Now, a few more factors. These are what we call the patient-related influencing factors, or whether they adopted the guidelines or not. For example, whether the patients got low motivation to change lifestyles into the recommended ones, or whether they got any particular concerns on their own health together with low adherence to therapeutic regimes. And lastly, we can see the primary care physicians-related potential influencing factors, one of which is that indeed they're actually quite concerned about the judgment of treatments were made mainly based on the individual patient's health conditions. Also, one concern is insufficient allied health support. I'm not sure whether it's the case in the public, probably not, but I think in some of the private settings, this could be one of the very important factors we have to really consider. So these are the factors independently associated with whether they use the reference frameworks or not, whether the guideline included sufficient local information, or whether there would be a reduction of professional autonomy. So, ladies and gentlemen, I do feel that we have to actually perceive it as a very important exercise for us to continuously enroll this information as the reference framework is progressing and changing from time to time. Because I do feel now we don't have a very structured framework to summarize everything and to ensure that these factors were brought to the attention of our policymakers to ensure the guidelines were adopted. Because when the guideline was firstly suggested to be implemented, and also the first meeting was launched, it lasted for almost 10 years before the guideline was mature. So in order for this to be adopted, to be fair, to ensure that the evidence base produced by a lot of experts very diligently should be well respected and try to implement to clinical practice in a way which will ensure that there will be a high penetration rate. So these are some of the suggestions for dissemination. Perhaps we need to really think about pop-up reminders of the electronic medical record system to ensure the physicians could probably actually adopt some of the recommendations. Could we really think about multilingual versions of reference framework? And also as we mentioned previously, mobile phone apps, as well as increased utilization of guidelines. So this would be actually up to us. Shall we include practices which will require additional allied health support in order for all these to be done, which are actually in fact recommended by the reference framework? So therefore, I think we really need to continuously update the content and presentation on the web. And in parallel, probably we need to actually disseminate it in a way which could reach the private physicians in a way which is user-friendly, making it easier to use with, and improve quality of patient care. So lastly, the strategies to remove the hindering factors should be further studied to enhance its adoption rate. So with that, I'm sorry for the time, and then once again, thank you very much for your kind attention. Thank you.